Okay, good morning, everyone. Welcome to term two for NB3 exam review. My name is Nick. Let's begin so that we can make progress. So, first, we're going to talk about defense mechanism. In Freudian psychology, you have three parts: the id, which is your basic instincts, your desire, and the ego, right? The ego is the mediator between your id and the superego. And superego is your societal rules, your religion, your morality. Think about an inverted pyramid. Your conscious is your ego, and then your subconscious, your id, and then your superego. In terms of ego defenses, these are unconscious adjustments in reality perception. It resolves or manages conflict between the id and the superego, and this is used for minimizing anxiety and adaptation to stressful circumstances. Please make sure to know all of the different defense mechanisms and how do they apply to the psychiatric disorders. Acting out, what is this? Avoiding emotions by bad behavior. It's attention seeking, it's socially inappropriate behavior. An example, child would seek parents, misbehaves at school, or adolescent engages in promiscuous sex during parents' divorce. Another one is denial. Denial is refusing to accept unpleasant reality. For example, patient thinks the doctor is wrong about the diagnosis, or heavy drinker believes she drinks socially. Projection. Projection is attributing feelings or emotions to others. For example, a cheater accuses a classmate of cheating off him. Regression is reverting to behavior of a younger person or a child. For example, a stressed adult watches cartoons from childhood. Sick adult wants parent to stay in hospital with them, or a hospitalized older child begins to wet his bed. So regression, you're going back, right? You're going back to a previous age or something, previous age of development, basically. Displacement, you're directing emotions to another person. For example, a patient is angry at a doctor after an injury, or a mother that's angry at husband yells at a child. So you're directing your anger, your negative emotion to another person. Reaction formation. This goes beyond denial. This one, you're turning your feelings into opposites. For example, a man who craves alcohol preaches abstinence. So totally opposite, right? Or a woman who despises her mother throws a big birthday party, celebration. Or a parent who despises a child shows extreme love and affection. When you think reaction formation, think opposite, okay? Intellectualization, what is this? So you avoid an emotion through reasoning. For example, a spouse going through divorce cites divorce statistics to friends to avoid admitting sadness. So that's intellectualization. Rationalization, on the other hand, is you distort the event so the outcome is positive. Example, I'm glad I got fired because I needed a change. I didn't really get a good score on the exam because I need to stay humble.
You're so dirty.
That's rationalization. You distort the event so that the outcome is positive. Repression. Repression is motivated forgetting. This is unconscious. You're consciously forgetting, right? Usually forgetting one particular memory or a fact, often something that happened long. For example, difficult period of childhood.
Do you mind cleaning those for me, please?
This is the first defense mechanism described by Freud. If you could please mute your mics. Thank you so much. Thoughts repressed to avoid guilt. So this is repression. Isolation of affect. This is isolating a distressing memory or an event, or failing to experience emotions of event. In cases of extreme trauma, childhood sexual abuse, physical abuse, verbal abuse. So for example, you can have isolation of affect. A person describes a rape without expressing sadness. So that's isolation of affect during times of extreme traumatic event in an individual. You can have this defense mechanism. Splitting, categorizing others at extreme. Either the world is full of wonderful people or the world is full of horrible people. For example, the patient loves her doctor because doctors are good, but hates nurses because nurses are bad. This defense mechanism is commonly seen in borderline personality disorder, which we're going to talk about later. Undoing. Undoing is engaging in contrary behavior. This is a reaction to an unhealthy or destructive thoughts or acts, trying to make things unhappen. Example, patient thinks about hurting someone, and the patient saw the person, then the patient acts overly nice to the person in response. So this is undoing, engaging in contrary behavior. You have a conscious act in your mind that you think I might hurt this person, but when this person comes in, you act very nicely to this person. This is undoing. Altruism. Altruism is one of the mature defense mechanisms that we have. This is a practice of concern for others. You care for others to reduce your stress or anxiety. For example, cancer survivors, they help others with the same disease. Another mature defense mechanism is humor. Relief of stress or anxiety with jokes and laughter. For example, a medical student jokes about studying for step 1. Sublimation, on the other hand, is not a mature defense mechanism. This is using negative emotions in a positive way. For example, an anxious person becomes a security guard, or an aggressive person becomes a boxer. So you have a negative emotion and you use that in a positive way. For these defense mechanisms, know the definition, know some examples. Okay? How about suppression? Suppression is a conscious defense mechanism. This is done intentionally to relieve your stress or anxiety. For example, you ignore stressful thoughts or feelings to cope. For example of this is, I'm not going to think about that now. Okay. For example, a nurse comes in and the patient has this stoma. The nurse needs to clean the stoma. And then, of course, if you can see this, it's smelly. It's a horrible sight. So you consciously suppress that thought in you and you do your job. You clean the stoma. So it's a conscious defense mechanism. Contrast suppression with repression. Repression is an unconscious defense mechanism. That's the caveat, okay? Suppression, conscious defense mechanism. Repression is an unconscious defense. We talked about the mature defenses. What's the mnemonic? SASH. Sublimation, altruism, suppression, and humor. Again, know the definition of each defense mechanism, know examples of each. Now we turn to psychotic disorders. What is psychosis? Psychosis is a loss of perception of reality. It occurs in a lot of disorders: delirium, schizophrenia, or drug-induced. There are 3 main manifestations of psychosis. You can have delusions, hallucinations, and disorganized thought. What are delusions? Delusions are strongly held beliefs that conflict with reality. High yield. Know all the delusions and the example. 1. Persecutory delusion. Example, the FBI is after me. Someone is after me. 2. Grandiose. I am the best medical student in the whole world. I am a millionaire. 3. Erotomanic. Bella Hadid is in love with me. 4. Somatic. There are worms in my chest. I'm dying inside. 5th, delusions of reference. You know the television newscaster? She's talking about me. from the TV. She's communicating something to me. 6, delusions of control. My body is controlled by aliens. Or I can control the weather. I can control the sun. Know the delusions, know the examples. Disorganized thought. This is shown by patterns of speech. You can have speech poverty, alogia, commonly seen in schizophrenia. Why do they have speech poverty? Because of thought blocking. There's something in the thought process. Thought blocking is a sudden, abrupt stop while talking, loosening of association, ideas discussed that do not follow each other, and you can have tangentiality, diverging from topic under discussion to another. These 3, thought blocking, loosening of association, and tangentiality, when you're doing your mini mental status exam, this is commonly seen in schizophrenia. Okay? Clanging also for schizophrenia, you have using words that rhyme but do not make sense. For example, the cow said how he had to bow. Another one is a word salad, incoherent words that make no sense, and perseveration, which is repeating words or ideas persistently, commonly seen in schizophrenia. Okay? Hallucinations. Hallucinations are sensory perceptions without external stimuli. 2 kinds. Visual, seeing things that are not there, common in hospitalized patients with delirium. Can you give me a substance that induces visual hallucinations? A commonly abused substance that has visual hallucinations during withdrawal. Anyone?
Is it alcohol?
Excellent. You have your alcoholic hallucinosis. The first 24 hours, right? You can have visual hallucinations without alcohol. Withdrawal. Alcohol withdrawal, the first sign is visual hallucinosis. Auditory. Auditory is hearing voices or sounds. It could either be a command, auditory hallucination, that someone is talking to you, like commanding you to do something. Either it's derogatory or non-derogatory. High yield auditory hallucinations, commonly a classic feature of schizophrenia. Rarely you can have olfactory, smell, or gustatory, or taste. I think for olfactory or gustatory, they are aura symptoms in someone who's having epileptic seizures. You can have olfactory hallucinations or gustatory hallucinations. Tactile hallucinations, commonly seen in withdrawal of what drug? What substance is commonly abused? The first sign is tactile hallucination. Anyone?
Is it methamphetamines?
It can be, but I'm thinking about cocaine. Right? Tactile, bugs crawling on skin. And of course, methamphetamines, they are uppers, right? Now let's talk about the disorders. Schizophrenia. What's the pathology? Excess central dopamine activity. Question, let's go back to term 1. How are we going to synthesize dopamine? From what amino acid? Anyone?
Phenylalanine to tyrosine.
Phenylalanine.
So phenylalanine to tyrosine. What's the enzyme that converts it? Phenylalanine hydroxylase.
Hydroxylase.
Excellent. What's the cofactor? Tetrahydrobiopterin, BH4. Tyrosine to what? L-DOPA. What is the enzyme? Tyrosine hydroxylase. What is the cofactor? Tetrahydrobiopterin, BH4. When I say hydroxylase, you say BH4. From L-DOPA to dopamine. What's the enzyme?
Dopa decarboxylase.
Carboxylase. When I say decarboxylase, what's the cofactor? What vitamin is the cofactor? B6.
B6.
Excellent. Because B7 is carboxylation reactions. Excellent. Now, dopamine to norepinephrine. What's the enzyme? Dopa beta
Beta
hydroxylase.
hydroxylase.
Excellent. From norepinephrine to epinephrine, it's a long one. Tell me the name. I forgot already.
PNMT.
PNMT. Excellent. What's the cofactor? SAM, right? SAM, which is a methyl donor. Before that, you have vitamin C, right? Before that reaction, you have vitamin C as a cofactor. Good job. Where is dopamine in the CNS? Where is it produced in the CNS? Guys, where is it produced in the CNS? Remember acetylcholine?
Substantia nigra.
Substantia nigra. Excellent. Don't forget don't forget your NB1 and NB2. Right? It's also high on the step. Okay? So dopamine. Now tell me the 4 dopaminergic pathways in the brain. 1. Mesolimbic. 2.
Mesocortical,
Mesocortical. 3.
nigrostriatal,
Excellent. 4. Tubero-infundibular. Okay? So those 4 pathways, remember them. Why? Because they are important in explaining schizophrenia. Just by knowing the dopaminergic pathways in the brain, you can understand the symptomatology of schizophrenia. Let's go back to pathology. So, excess central dopamine activity. Therefore, what's the treatment? Of course, dopamine antagonist used for therapy. Also, we have a hypofunction of the NMDA glutamate receptor. Can we diagnose schizophrenia via imaging? Yes or no? Can we diagnose schizophrenia just by imaging itself? Yes or no?
No.
No, of course.
Oh,
You need to do signs and symptoms. You need to have delusions, hallucinations, disorganized speech, disorganized thought, and negative symptoms. But in terms of MRI or CT scan, you can see, look here, lateral ventricular enlargement. So your lateral ventricles are going to be, they're going to be enlarged, right? Could you tell me the pathway of the CSF in the brain from lateral ventricles? Where does it go? Just a review.
to the third ventricle,
Via what?
the interventricular foramen.
Exactly. Your foramen of Monroe. From third ventricle to the fourth ventricle via what?
Cerebral aqueduct.
Excellent. Cerebral aqueduct, or in the olden times, aqueduct of Sylvius. Right? You have the Sylvian fissure. He also discovered the cerebral aqueduct. So it's an aqueduct of Sylvius. And then from the fourth ventricle to where? 2 lateral, 1 medial. Tell me the lateral.
Foramen of Lush,
Luschka. Excellent. Foramina of Luschka, because it's plural, which is lateral. And then you have 1 medial. What is that?
Majandi,
Magendi.
Foramen of Magendi. Excellent. Then the CSF, we're going to reabsorb where? Arachnoid granulations, right? Where? In the superior sagittal sinus. Excellent. So it's just a review. So in terms of PET scan, you can see hypoactivity in the frontal lobe or hyperactivity of the basal ganglia, specifically in what part of the frontal lobe this schizophrenia affects. Specifically where in the frontal lobe? Prefrontal cortex, your PFC. Why? What is the function of your prefrontal cortex? Anyone? So your executive planning, the plan, everything that involves planning, think prefrontal cortex. So in the PET scan, hypoactivity of the frontal lobe. You can have hyperactivity of the basal ganglia. How are we going to detect that? You inject glucose in the PET scan. And you can see hypoactivity or hyperreactivity. This is called, you're going to learn term 4 about the Warburg effect commonly seen in cancer, or angiogenesis, wherein parts of the brain will gonna increase uptake of that glucose. Okay, but for now, when you think of MRI and CT for step 1, think lateral ventricular enlargement, ventriculomegaly. In terms of epidemiology, this is much more relevant in step 2. Lifetime prevalence, 1%, 0.5 to 1%, basically. Slight male predominance and occurs in adolescence or young adulthood. Risk factors, this is geared to step 2. Living in urban areas or cities, and immigration. According to a UK study, immigrants are 10 times more at risk of schizophrenia. But other risk factors, obstetric complications, placenta previa, hemorrhage, like preterm labor, blood group mismatch, for example, your RH, fetal hypoxia, maternal infection. What are you going to give in second pregnancy of someone who's RH positive mother? What are you going to give to prevent erythroblastosis fetalis? Just a review.
Rogam.
Rogam. Excellent. Good job. Another risk factors, cannabis use. So if you use cannabis early in life, what happens? Your frontal lobe actually shrinks. So you have increased risk of schizophrenia later in life. Usually in adolescence, unclear if this is a cause and effect, and you have mild symptoms may lead to cannabis use. Hallucinations, main manifestation, auditory hallucinations. Schizophrenics, they hear voices, they hear strange sounds, and they also have delusions. Know all of them, know the examples. Disorganized speech, as I've said, tangential speech, meaning they change topic frequently, they may not answer the question, and circumstantial. It's a long roundabout answer to questions, but they always go back to the main idea. That's circumstantial. Tangential, they won't go back to the main idea. The question that you ask, they won't go back. They change the topic frequently. You can also have cognitive impairment in schizophrenia. You can have difficulty processing information, poor attention, poor learning, and your memory. Now, this is good. Positive symptoms. What causes positive symptoms in schizophrenia? In terms of the 4-dopaminergic pathway, what causes the positive symptoms?
Overactivity of the mesolimbic.
Increased excellent. Increased dopamine in the mesolimbic pathway. So you can have abnormal behaviors, hallucinations, delusions, disorganized thought. This is related to dopamine activity. What are we going to give? You give antipsychotics. Negative symptoms. How about negative symptoms? In terms of the pathway, dopaminergic pathway.
Underreactivity of the metacortical.
Excellent. Decreased dopamine in the mesocortical pathway. Think about 5 A's for your negative symptoms. Anhedonia, no more pleasure. Alogia, poverty of speech. Asociality, you cannot engage in social interactions. Avolition, lack of motivation, cannot complete tasks. And affect, flat affect. Know the 5 A's, negative symptoms, high yield. What's the complication of someone who's a schizophrenic? Higher risk of suicide. Remember, 5% of schizophrenics, they commit suicides. And 10% of all suicides, they occur in schizophrenics. What's the diagnosis? DSM-5. At least 1 month of 2 or more of the following. You need to have delusions. You need to have hallucinations. You need to have disorganized speech. You need also to have disorganized or catatonic behavior, and you have negative symptoms. But you need to have 3 of delusions, hallucinations, and disorganized speech. That's essential for your diagnosis of schizophrenia. It is a continuous sign for at least 6 months. Okay? Again, what's the DSM-5 diagnosis for schizophrenia? At least 1 month of 2 or more, but you must have the delusions, hallucinations, and disorganized speech. That's a must. Plus, disorganized or catatonic behavior and your negative symptoms, your 5 A's. This should be for at least 6 months. Okay? What's the treatment? Antipsychotic drugs. Could you tell me antipsychotic drugs that you know? First generation antipsychotics?
Haloperidol.
Haloperidol, excellent. What else? Fluphenazine, what else? That's high dose. Let's go low dose. Chlorpromazine, remember the antiemetic? Chlorpromazine. Well, that's a second generation antipsychotic, yes. Risperidone, but we're gonna go there later. What else? Chlorpromazine, thyroidazine, okay. Second generation, or your atypical antipsychotic. Someone said risperidone, olanzapine, quetiapine, your Seroquel. Good. And you can also do psychotherapy. Did you talk about signs and symptoms of your antipsychotics or vaguely? Yes or no?
Yeah, we talked about like dystonia, akinesis.
Okay, excellent.
Yeah.
Good. Okay, let's do it. Let's do it then. All right. First generation antipsychotics, Haldol, fluphenazine, increased risk of extrapyramidal symptoms. Why is it called extrapyramidal symptoms? Did you ever wonder that? Why is it not pyramidal symptoms? And what's the difference?
Because they affect the cerebrospinal tracts and like the ones outside of the pyramid.
Excellent. This is about basal ganglia, right? Extrapyramidal. While the pyramidal is your corticospinal tract in your corona radiata. Good. Excellent. EPS, extrapyramidal symptoms. What are those? One, what's the first thing that you can see? If you're
Dystonia.
given antipsychotic to someone, you first are going to see acute dystonia. What is this? Someone describe it to me.
Sustained head and muscle contractions.
Okay, what are we going to give? You give anticholinergics, right? You give muscarinic antagonist. Let's go back to term one. What is that drug? Anticholinergics, like the same class as atropine. What is that? Benztropine. Now, benztropine, sometimes it's too slow. Okay, so what can we give? That's much faster. Benadryl, diphenhydramine. It's much faster for acute dystonia. Next, another EPS symptom. Anyone?
Akathisia.
Akathisia. Can someone describe it to me, please? What is akathisia?
Restlessness.
Excellent. They can't sit still. They're just pacing around the room. What's the treatment for akathisia? You could do benzos. You could do benzodiazepines, GABA receptor agonist. Next. What's another extrapyramidal symptom? So we have acute dystonia, we have akathisia. How about pseudo-Parkinsonism? Pseudo-Parkinsonism, right? You can have tremors, resting tremors. You can have, what else is in there? They look like they have Parkinson's, but they don't have it, right? This is due to what? Decreased dopamine in the nigrostriatal pathway. So what are we going to give to someone who has pseudo-Parkinsonism? Again, your favorite, your antimuscarinic, anticholinergic, your benztropine, or you can give, what is that drug? Amantadine, commonly used in influenza A. Last one, last EPS symptom.
Tardive dyskinesia.
Excellent, tardive dyskinesia, but this can only be seen if your patient has been taking Haldol for a couple of years. In the vignette, they're going to say lip smacking or grimacing. When you see that, think tardive dyskinesia. High yield, what's the drug of choice to treat tardive dyskinesia? Your VMAT2 inhibitors. Remember your VMAT from norepinephrine pathway, right? It releases into the synaptic cleft. Remember your reserpine is a VMAT inhibitor, right? But that is not used clinically. It is only used in research. So this is from term 1. So what are you going to give? VMAT2 inhibitors. Clinically, you can give valbenazine or deutetrabenazine. So those are your 4 extrapyramidal symptoms. High yield, know them. No examples, know the treatment. Okay, how about psychotherapy? What is our favorite psychotherapy for schizos? It's always
DBT?
well, the dialectical behavioral therapy. Yes, we can also use that one, but that's commonly seen in borderline personality. That's the gold standard therapy, dialectical behavioral therapy. But for schizo, we use CBT, cognitive behavioral therapy. Okay, contrast schizophrenia from schizophreniform. Schizophreniform is you have all the symptoms of schizophrenia, but less than 6 months. That's it. Timeline. Timeline matters here. From 1 to 6 months. Always less than 6 months. How about a brief psychotic disorder? Less than a month. Okay? Full remission within 1 month. So brief psychotic disorder, less than a month, you have psychotic symptoms. Full remission within 1 month, it follows after a stressful life events. If it's more than 1 month, but less than 6 months, you have schizophreniform. If it's more than 6 months, you have schizophrenia. Okay, so timeline here. Go ahead.
So I just figured this one out anyway, because I thought brief psychotic disorder used to have an active phase, but if it turns out that you don't, you just need one core symptoms. So if it's like this one core symptoms over a month, what do you call that?
If you have one psychotic symptoms over a month, so do you have delusions? Yes or no?
It's just like one, just like say he has delusions only. But it's like less than a month, they consider that this. But if it's like over a month, what do you consider that as?
It could be a delusional disorder.
Okay, yes. Okay.
Yeah. You can also have that one. Okay?
Yeah.
Good. But here, make sure know the timeline. The timeline matters. They won't gonna trick you. They're gonna have all of those signs and symptoms and they're gonna specify the months. Okay? I don't know if IEA still has exam review for you guys, but if you can, attend their exam reviews. Okay, we also have schizophrenia with mania or depression, schizoaffective disorder. So schizoaffective disorder, we need to contrast this one with MDD, major depressive disorder, with psychotic features. So what's the difference? In schizoaffective disorder, you have more than 2 weeks of no depression or mania for schizoaffective disorder, right? You have an absence of mania or depression. For MDD with psychotic features, the psychotic symptoms only occurs concurrently with depression. That's the main difference. Schizoaffective is very difficult to diagnose, especially in psychiatric patients, because you need to know the timeline. What if the patient comes into you and he has psychosis? He doesn't know if he has mood symptoms, right? So this is very, very difficult to diagnose schizoaffective disorder. But like I've said before, schizoaffective disorder, psychosis in the absence of mania or depression for more than 2 weeks, MDD with psychotic features, you have the psychosis concurrently with the depression. Again, this is a good slide, schizoaffective disorder. You can see that with 1 month to 6 months. So the psychotic symptoms, you have more than 2 months of no mania or depression. Mood disorder with psychosis, look, the psychosis only occurs during episodes of mania or depression. Okay, delusional disorder. You have a delusion, whatever, persecutory, erotomanic, whatever. It lasts 1 month or longer, but you don't have no abnormal behavior. Example, man believes he's being followed for past 2 months, or you frequently check for someone behind him. It cannot be persuaded he is safe. However, no hallucinations, no disorganized thought, and no negative symptoms. So definitely not schizophrenia. You can also have folie à deux, a madness of two, wherein a close friend shares the delusions. Again, this is a good slide for psychotic disorders. Know the disorder, know the features, and the time frame. Okay? Next, we're moving on from psychosis to mania, manic episodes. So could you tell me, how do you know that your patient is manic? How do you know that your patient is in a manic episode?
Their daily activities.
Okay, increased daily activity. They're pacing around the room. They can't sit still. Okay, they can't sleep. Right? They have increase in energy levels. Right?
They can't work. Though.
Excellent. You can have a flight of ideas. So difficulty in performing activities of daily living. Right? Excellent. Disinhibition and irresponsibility. They waste money. They go to Amazon. They shop all day. They wear no clothes. Grandiosity. They have increased self-esteem, confidence. I can do anything in the world. Typical case, you can have change in mood to elevated state, not sleeping, altered behavior, and disruption of social functioning. I yield, no, dig fast. This is your manic episode. Symptoms for at least 1 week, most of the day, dig fast. Distractibility, irresponsibility, grandiosity, flight of ideas, agitation, less sleep, and talking too much, or pressured speech. Hypomanic episodes, similar to mania but less severe. Why? Because there is little or no impairment in function. You have inflated self-esteem, but you don't have any delusions of grandeur. They are more organized thought than mania. Remember, you have little or no impairment in function. They can still go to work, right? You have more energy that leads to productive activity. Contrast this with mania, which is unproductive. And you have a milder risk-taking behavior. Hypomanic episode lasts at least 4 days. You have no psychotic symptoms, right? Typical case, you have change in mood to elevated state, and you have continued social functioning. Hypomanic episode, don't forget, continued social functioning and little or no impairment in functioning. They can still go to work. Now let's talk about bipolar disorder. What's the difference between bipolar 1 and bipolar 2? In bipolar 1, you have a manic episode plus or minus depression. Manic episode equals bipolar 1. What if you have a manic episode 10 years ago? Is it still bipolar 1? Yes or no?
Yes.
Of course, yes. One episode, whether it's 10 years ago, 5 years ago, 20 years ago, as long as there is one manic episode, it is always bipolar 1. How about bipolar 2? You have hypomania and depression, and there is no manic episodes. Signs and symptoms of manic episodes, big, fast. Psychotic features, bipolar. You have hallucinations or delusions associated with severe forms of mood disorders. They may occur in bipolar disorder or depression. Always occur together with mood symptoms. And don't forget, psychosis without mood symptoms, that's schizoaffective disorder. Now, cyclothymic disorder, mild mania, right? It's not mania. It's like mild only, maybe a hypomanic episode, and it's not depression. It's mild depressive symptoms only. They do not fully meet the criteria for your DSM-5 for hypomania or major depressive disorder. And they can go over at least 2 years. So they cycle, highs to low, high to low, high, low, high, low, for at least 2 years, never absent for more than 2 consecutive months. Cyclothymia, mild mania, mild depression. Symptoms come and go over at least 2 years. So this is a bipolar disorder. You can see the fluctuation of mania or hypomania and depression. It's called bipolar because you have 2 poles, you cycle. And you can have, in bipolar disorder, you have periods of euthymia or normal mood. So what's the treatment for bipolar disorders? I yield mood stabilizers. Lithium. What's the mechanism of action of lithium? How does it stabilize the mood? To be honest with you, the answer is we don't know. We don't know, but there is a hypothesis. Does anyone know what's the hypothesis of how does lithium affect mood?
I think they just said it basically takes part in a bunch of different pathways.
So I've read research from NBMI, and the main, I think the theory is it affects your inositol triphosphate pathway. Remember your GQ, your IP3 and DAG, right? It affects your secondary messengers. That's a theory. But if you know the exact mechanism in the future, do a research on that, and you're gonna get Nobel Prize, I think. So side effects of lithium. Did you talk about the side effects? Yes or no?
So
Would it
I
be like
don't
hand
recall.
tremors?
Because I don't know what they teach you. Did they teach you the drug and the side effects, or they
tell
just
us
say
the
lithium
drug.
and then move on?
Yeah.
They just said that it's like this one has less side effect than the others. So forth.
Okay. So maybe term 4. But for now, okay, let's talk about lithium side effects. First, EKG changes, right? Think about flattening of the T wave. Remember from term 1, right? If you have high T wave, what does it mean? If you have high T wave from term 1, hyperkalemia.
That's the ventricular repolarization.
No, only the T wave. Hyperkalemia. If you have an increase in the T wave. So for this one, you have flattening of the T wave. What else? SE node. You can have bradycardia. Where is SE node located? Where is it located?
The right atrium.
Right atrium. Specifically where? Crista terminalis. Junction of what? Junction of SVC and IVC. You have the crista terminalis there. Don't forget that, please. When you go back to Grenada, if you get a chance, go to the open lab hours. I used to teach anatomy there. Please go there and look at the cadaver and figure it out, okay? What else? Lithium. Nephrogenic, diabetes insipidus. Let's go back to term 1. What kind of urine do you have? Nephrogenic DI. Dilute or concentrated? Nephrogenic.
Dilute.
Careful. Nephrogenic diabetes insipidus. This is not SIADH, okay? Careful. What is the urine in nephrogenic DI? Dilute or concentrated? Someone said it. Don't be shy.
I think it's dilute.
Dilute urine. Dilute, people. Dilute, right? Why? What's wrong? What receptor is wrong in
receptors
nephrogenic
are wrong.
DI? The receptor. Excellent. What receptor?
V2
receptor. Do we have V1 receptor? Yes, we're going to find V1 receptors in your blood vessels, specifically where? Arterioles. What's the function of the V1 receptor? For your blood pressure. Remember, the arterioles are the one who's going to detect your blood pressure, whether they constrict or they dilate, right? Don't forget your term 1 material. Okay? So V2 receptor. So basically, you have, in the collecting duct, you have the principal cell, right? This is from CPR2, from the renal module, right? If I can remember it correctly. In the principal cell, the ENaC channel is there. You have the sodium going in, K going out. right? The Vito receptor is expressed in your principal cell to accept water, and when the water goes, sodium follows it. If you have lithium, lithium goes into the principal cell via a co-transport of sodium. So sodium and lithium, they go inside together. It's a symport. Okay, they go inside the principal cell. So what's the treatment of nephrogenic diabetes insipidus then? You block the ENaC channel. Think about amiloride. Okay, amiloride. Think about that one. Paradoxically, you could also use hydrochlorothiazide, a thiazide diuretic, to reverse your nephrogenic diabetes insipidus. What other drugs can cause nephrogenic diabetes insipidus? From term 1, treatment of SIADH. What's a drug?
ADH.
Demeclocycline. Remember? Demeclocycline is a treatment for your SIADH. If you've overdosed of that, it can induce nephrogenic diabetes insipidus. Think about diabetes insipidus and SIADH as opposite. They are opposite to each other. One, nephrogenic DI, dilute urine. The other one is concentrated urine. Nephrogenic DI, if the urine is dilute, what happens to the concentration of ions in the blood? Normal or increase. The other one, it's a concentrated in SIADH. You have a concentrated urine. What happens to the serum chemistries in the blood? They are decreased. Okay. Another one for lithium, tremors. Tremors. Why do we have tremors? That's the first thing that you can see in your patient. When you're given lithium, they can have tremors. Why? Increased iron concentration in the substantia nigra. It increases the iron concentration, and iron is very cytotoxic in the brain. What else? There's a lot. Okay, that's lithium for now. Next, valproic acid, which is an anticonvulsant. When you hear valproic acid, please think hepatotoxicity. So think about your liver function. Test what zone in the liver metabolizes valproic acid. Zone 1, zone 2, zone 3. What zone in the liver normally metabolized your drugs? Zone 1, zone 2, zone 3. Let's go back to exam. What's this? Exam 2. Remember the liver zones, guys? Zone 1, zone 2, zone 3. What zone metabolizes?
Well, I remember zone 3 gets the blood flow, right?
Okay. So zone 3 actually, your CYP, your cytochrome P450 is there, people. Okay? Right? So for this one, make sure you integrate the materials. I always advise you, like when you go over your notes, integrate the materials as much as possible. It will gonna help you in the future, specifically going on to term 4. Okay? Integrate materials as much as possible. So when I say valproic acid, hepatotoxic, check the liver function test. Lamotrigine, when I say lamotrigine, always think Stevens-Johnson's syndrome. SJS, what happens to the skin? You can have eruptions, you can have bulla, right? Positive Nikolsky sign or negative Nikolsky sign? Or Stevens-Johnson's? So they rupture. So it's positive or negative Nikolsky sign? If they rupture.
Positive.
Positive, of course. They're positive Nikolsky sign. So lamotrigine, think SJS. Carbamazepine, also think hepatotoxic. So valproic acid and carbamazepine, they block sodium channels. Think about hepatotoxicity. Lamotrigine, always think Stevens-Johnson's syndrome. There are other drugs that can cause Stevens-Johnson syndrome. You can have sulfamethoxazole. All of that we're going to learn in next term. No, term 4. You could also use antipsychotics. We'll talk about that. Or ECT, electroconvulsive therapy. Patient came in. He's suicidal. He doesn't react to SSRI, SNRI. He doesn't react to TCA. He has a plan. You admit him, of course. What are you going to do? Treatment resistant. What are you going to do? A patient came in, guys. The patient is resistant to treatment. What's the next best thing that you can do? The patient is suicidal. The patient is suicidal. The answer is right there after antipsychotics.
ECT.
ECT. Don't forget that one. Okay. Treatment resistant depression, treatment resistant bipolar disorder. As long as it's treatment resistant, you still have ECT. A patient's coming in, he's suicidal now. You can always do ECT. Can you do it in pregnancy? Can you do ECT in pregnancy? Yes or no? Is it safe in pregnancy?
Yes.
Yes, excellent. So you can actually, it is very, very safe in pregnancy. Good job. Don't forget that your antidepressants, if you use them as your monotherapy, could you give me an example of antidepressants? SSRIs, right? Example. Your Prozac, right? Your Paxil. What else? SNRIs, you have your venlafaxine, your duloxetine, right? TCA, tricyclics, amitriptyline, more of this in term 4. You're going to enjoy pharmacology in term 4. Don't forget, monotherapy with antidepressants, they may cause mania. Okay? Common side effects of SSRI, sexual dysfunction. That's why the patient will gonna say, Doc, I don't want to be on Prozac because I have decrease in libido, premature ejaculation. So they have effects, okay? So when you think SSRI, think of the sexual side effects. Monotherapy of antidepressants in bipolar disorder may cause mania. So don't do monotherapy, okay? Don't just prescribe one antidepressant. They should be in combination with a mood stabilizer. You can combine a mood stabilizer and an antidepressant, okay? Now let's go to the other pole, mania. Now we're talking about depression, major depressive disorder. You have depressed mood. You have anhedonia, loss of interest, appetite, weight changes. Everything that's on this slide, know them. This is your depression, your SIG-E caps. That's high yield, SIG-E caps. Psychomotor agitation, excessive motor behavior, or they can have psychomotor retardation, they have low voice, few words, they're slow to answer questions. In major depressive disorder, you have sleep disturbances, high yield, decreased REM latency, meaning the REM starts quicker after the sleep onset. What type of depression can you have hypersomnia or excessive sleeping? Atypical depression. Okay, only in that part you can have hypersomnia. So again, as the summary, major depressive disorder, think altered sleep rhythms, high yield, decreased REM latency, meaning the REM starts quicker after sleep onset. Also, increased cortisol, that's high yield for major depressive disorder. You have elevated serum cortisol. Your body is in a lot of stress. That's why your body is producing cortisol. So in patient depression, if you are depressed, you can also have cognitive impairment. We call this one pseudo-dementia. So how are we going to differentiate real dementia from pseudo-dementia of depression? So here's a good table. Put a star on this table. This is high yield. In pseudo-dementia, the mood is depressed, rapid onset, rapid progression. And they answer the question like, I don't know. But if you keep on asking them questions, they finally answer. All right. So suicide risk is very high in your pseudo-dementia. In dementia, the mood is variable. However, the onset and progression, look, it's slow. Right? They try to answer the question, but they can't. The suicide risk is low. High yield, SIG-E caps, major depressive disorder. What's a DSM-5 criteria? 5 symptoms for 2 weeks. SIG-E caps, sleep disturbance, lack of interest, guilt, energy loss, concentration, decreased concentration, Appetite or weight changes, typically decrease in appetite. You can have psychomotor symptoms and suicidal ideation. Psychotic features. We'll talk about this one. So, how about persistent depressive disorder? This is a low-grade form of depression. This is less severe, but more chronic. You have depressed mood most of the time, and it lasts, again, the timeline, at least 2 years. You're depressed for at least 2 years. You are no symptom-free. You still have the SIGI caps lasting for more than 2 months. So this is your persistent depressive disorder. The old name is dysthymic disorder. At least 2 of the following: hopelessness, decreased appetite, sleep problems, low energy, low concentration, and low self-esteem. There are different subtypes of major depressive disorder: atypical, melancholic, catatonic, psychotic, mixed features, anxious, and seasonal. Focus on atypical. In the vignette, my legs feel heavy, my arms feel heavy, or my body feels heavy. We call this one laden paralysis. L-E-A-D-E-N, laden paralysis. They just felt heavy. If you see that in the vignette, think atypical. Or, oh, I'm eating so much, I'm eating a lot, I'm getting a lot of weight. While having laden paralysis, while having hypersomnia. So very atypical. It's not like a depression. So we call that atypical depression. You have mood reactivity. They're able to react to pleasurable stimuli. This is a differentiating factor from MDD. Your atypical depression, you have mood reactivity. They feel better when good things happen. They're eating and sleeping all the time, heavy or laden feelings in limbs, okay, in the vignette, and they're sensitive to rejection. Atypical depression, what are we going to use? Always SSRIs. Don't forget sexual dysfunction in your SSRIs. Of course, it's winter time, guys. So sometimes we feel depressed, right? So worsening depression in fall and winter. What's the treatment? Look at this guy here. He's in front of a lamp. We call this a phototherapy for seasonal depression. What's the treatment for MDD, major depressive disorder? Psychotherapy, of course, CBT, or interpersonal. You can give antidepressants, SSRIs, and SNRIs. SSRIs, again, major side effect, sexual dysfunction. SNRIs, major side effect, heart block. Need 4 to 6 weeks to assess efficacy. So if you give antidepressants, tell your patient that it will take a while. It needs 4 to 6 weeks to be effective. And there's a new FDA guideline in prescribing antidepressants. It can actually increase the risk of suicide. Don't forget to tell your patient that. Okay, it's a new FDA guideline for your antidepressants. If they are still symptomatic, you increase the dose, you add or switch drugs, right? And of course, fluoxetine. This is the most widely studied in your adolescents. Fluoxetine has the highest half-life of your SSRIs. You could also do ECT. And if the patient is high suicide risk, the patient has a plan, the patient knows how to do it, where to do it, access to firearms. If the patient is high in the suicide risk, always the correct answer is admit the patient. Okay, don't forget that. Suicide, commonly seen in depression and bipolar disorder. 95% successful attempts have psychiatric diagnoses. Those who are depressed, bipolar, substance abuse, or schizophrenics. Remember, women have more attempts. However, they are less successful. Why? What's the method? Overdose and cutting. So it's not that deadly. You're doing more attempts, but less successful. Men, on the other hand, has a fewer attempt, but they are more successful. Why? Because the method is firearms. or hanging, right? So if you go in the future, I think a good research question is, why is it that men chooses like firearms or hanging, like deadlier methods than women? Is it environmental or there's a genetic component to that? That's a good research question in the future. Most common method, of course, firearms. So when a patient comes in, always ask, do you have access to firearms? And the suicide risk increases with access to guns. High yield, know the risk factors. Sad person. Sex, male, 1 point. Age, young adults or elderly, another point. If they're depressed, point for that. Prior attempt. This is the higher risk group. If they have a prior attempt, they're automatically higher. Okay? Ethanol or drugs, rational thinking, psychosis, sickness, organized plan, no spouse, and stated intent. So know the risk factors for your suicide. What's the assessment? Ideation, you ask. Do you have any thoughts of hurting yourself? Do you have any thoughts of hurting others or harming others? Do you have any thought of destroying property? All right. Do they have a plan? Do you have access to firearms? Check for plan, check for intent, and they're high risk if all three are present. If they have suicidal ideation, if they have a plan, and they have an intent. What are they going to do if they have all three? Hospitalization, because they're high risk for doing that. Suicide. Now, catatonia. If you're older, like I am, in DSM-4, we have catatonia as a category, as a symptom of schizophrenia. So as a modifier, I'm sorry. So remember, DSM-4, you have schizophrenia. What's the modifier? With catatonic behavior or without catatonia. That's a modifier. Now, DSM-5, they remove that. We no longer have catatonia. It's a second category. Okay? So what is catatonia? Inability to move normally. For example, if you ask your patient to raise their hand like this, they're going to stay that for an hour or 4 hours. They're going to stay in that position. That's catatonia, inability to move normally. So any body part, you raise their hands like that, they're going to be in that position for many hours. It occurs in patients with mental and medical illness, depression, bipolar, schizophrenia. What's the treatment? Benzodiazepines. What's the mechanism of action of benzos? Anyone? Benzos? Guys, what's the mechanism of action of benzodiazepines?
GABA agonist.
GABA agonist, GABA A receptor agonist. And then what happens to the cell? It opens, right? You have chloride going into the cell. What happens to the action potential? Prolonging the action potential, right? You can never have another signal that comes in. That's why you feel sedated, right? Always incorporate materials, guys, when you're doing this, always. Another, ECT, and you avoid anti-psychotics. Why? Remember serotonin syndrome? Did you talk about serotonin syndrome? Yes or no?
I don't believe so.
No.
Okay, that's term 4. Serotonin syndrome. And for your antipsychotic, no, I'm sorry, I misspoke. Antipsychotics, think about neuroleptic malignant syndrome. If we have the antidepressants, the SSRI, the TCAs, SNRIs, think about serotonin syndrome. More of these in term 4. But for now, catatonia, benzodiazepines. Next, panic attack. Panic attack, sudden onset of intense fear. No trigger, right? It lasts for minutes to an hour. So you can have physical symptoms. Look at this girl here. She has palpitations, racing heart. She's sweating, trembling or shaking. She has chest pain or discomfort. She thinks she's having an MI. So diagnoses, 4 or more of the following. Okay. Panic attack, how do we diagnose? Derealization, depersonalization. Derealization, items in the room look foggy or unreal. Depersonalization is an out-of-body experience. They look detached. They're looking at self from above. I remember I had one time I had a 12-hour shift, and then I was sleeping, and I wake up, and for a split second I don't know where I am and who I am. It's very, very scary, guys, to be honest with you. So that's derealization. You don't know where you are. Why am I here? What country is this? Depersonalization. Who am I? So at the split second, right? This is a very, very scary experience. So a panic disorder, you have a recurrent, unexpected panic attacks. No obvious trigger, no, not post-traumatic, and not in response to phobia. And the attacks is followed by 1 month or more of persistent concern or worry about panic attacks and change in behavior to avoid the attacks. There's a genetic component. First degree relative with panic disorder increases the risk. Also most common in patients who has a history of physical or sexual abuse and life stress. What's the treatment? Always CBT plus SSRI. The running joke in psychiatry is if you don't know the answer in New World, on step 1, just pick CBT plus SSRIs. You can also do antidepressants, of course, and benzodiazepines. Specific phobia. You have a fear of a specific object or a situation. It leads to avoidance. You avoid that behavior. It persists for more than 6 months. Common. Lying, dental procedures, and blood draw. Okay. No social anxiety disorder. That's high yield. Excessive fear of embarrassment in social setting. I don't want to present tomorrow. I'm going to present. I'm anxious, right? I avoid that. I feel embarrassed in front of my peers. I fear that I'm going to be humiliated or they're going to judge me for who I am. So that's social anxiety disorder. Agoraphobia is I don't want to get out of my house. Fear of living a safe place for public setting. I don't want to go to the elevator. What if I'm going to get trapped? Right? Fear of needing to flee with no help available. This is not a fear of scrutiny and embarrassment. Example, fear of empty bus. Why? There's no people there. What if something goes wrong? Right? There's no people to help me. There's no help available. This often occurs with panic disorder. And often the patients fear panic attack in a public setting. What's the treatment? Again, SSRIs for frequent exposure. But the initial treatment, right, is you have exposure therapy. You expose them to that distressing stimuli. Also, you can do beta blockers. Why? To blunt the physical symptoms. Remember the autonomic hyperreactivity, the sweating, increased heart rate, right? You give beta blockers, propranolol, non-selective, or benzodiazepines for infrequent exposure. Treatment, behavioral therapy. Initial treatment always behavioral therapy. You can do exposure therapy or systematic desensitization. In systematic desensitization, imagining exposure to feared stimulus step by step. And exposure therapy, you confront the feared stimulus in a safe, controlled manner. The fear is reduced over time. GAD, generalized anxiety disorder, chronic persistent anxiety for more than 6 months. Okay, more than 6 months. 3 or more of the following: restlessness, fatigue, difficulty concentrating, irritability, muscle tension, sleep disturbance. You can read that. Treatment always CBT. If we have 3 or more of the following symptoms, you could use SSRIs. However, combination is the most effective. Again, I told you the running joke. If you don't know the answer is always CBT plus SSRI. Now let's talk about obsessive compulsive disorder. What are obsessions and what are compulsions? Obsessions are recurrent thoughts. They're intrusive and unwanted, and you attempt to ignore them or suppress them, and it causes you distress in your life. In order to deal with obsession, you do compulsive behaviors. These are repetitive behaviors or mental acts. Why are you doing that? To relieve Obsessions, for example, a woman who's going with a divorce, she keeps on cleaning the house. There's a divorce pending. She keeps on cleaning the house. How is she dealing with that? With the compulsion. The compulsion is cleaning the house. So hand washing, example of compulsions, you are checking the stove. Now, obsessive compulsive disorder versus obsessive compulsive personality disorder. How are we going to differentiate the two? Anyone?
The routine.
Personality disorder
The
becomes
personality is controlling.
Look at the slide in front of you and tell me the difference between obsessive compulsive disorder and obsessive compulsive personality disorder. In obsessive compulsive personality disorder, it's ego syntonic, meaning the behavior achieves the goal. For example, the goal is to go to the grocery store. People who has obsessive compulsive personality disorder, they keep lists, so they write down everything that they need, and they get out of the house and go to the grocery store. That's ego syntonic. In obsessive compulsive disorder, it's ego dystonic. Remember, D, disorder, D, dystonic. Meaning the behavior conflicts with the goal. For example, the goal is to get out of the house. However, if I have OCD, I keep on doing compulsions. I keep on cleaning the house or checking the stuff. I can't get to my goal. So that's the difference. Okay? In OCD, personality disorder, think ego syntonic. The behavior achieves a goal. In obsessive compulsive disorder, it's ego dystonic. The behavior conflicts with the goal. OCD commonly co-occurs with schizophrenia, bipolar, eating disorders, and Tourette's disorders. What's the treatment? The treatment is cognitive behavioral therapy. You can have exposure and response therapy. You expose the patient to the obsessive thoughts and the image, and they respond with non-compulsive behavior.
Nick, I have a question real quick.
Go ahead.
What's the difference between flooding and exposure therapy? Is it besides the timeline, like it's super rapid in flooding versus exposure?
Flooding versus exposure therapy. I think flooding is a form of desensitization, a form of exposure therapy. I don't know. Does anyone know?
What I understand, flooding starts with like the most anxious, hypothetical situation. So you're just flooding them with, their worst fear. Whereas exposure therapy, they emphasize a graduated exposure. Like you start with the least, and then you give them like coping tools, and then you increase the exposure, and they cope with it.
Excellent. For example, I have a fear of snakes.
I agree. Sorry. Yeah.
I have a fear of snakes. In flooding, you put me in a room that are full of snakes in an instant. That's flooding. I'm overwhelmed. I am in a room full of snakes. Wait a minute, what am I doing? And you lock the door. That's flooding therapy. Exposure therapy is first an image of a snake, then a stuffed toy that is a snake, then a real snake. Okay? So flooding all at once. I'm afraid of snakes. Let me put you in a room that are full of snakes and close the door behind you. You need to deal with it. Right? That's flooding at an instant. Why? What's the purpose? Extinction. You want to have that behavior to be extinct. Right? In exposure therapy, step by step, baby steps. Is that good?
I just have like a funny story to share, if I may. When I learned how to swim, I took classes at the YMCA, and we would do, like testing the water and then have the boards and kicking our feet and things like that. But when my brother taught his kids how to swim, he just threw them in the pool.
Exactly. So that's flooding.
Literally.
Okay. That's a good one.
My question is, did they learn how to swim?
Yes, yes, they learned. They're not afraid of water or anything.
So it works then, right? Okay, either exposure or flooding. Now you won't ever forget flooding versus exposure therapy. Now let's talk about PTSD, post-traumatic stress disorder. This follows a traumatic event: rape, physical assault, war. You have thoughts, nightmares, but more importantly, flashbacks. You have reliving of the experience. They avoid reminders. You have hypervigilance. They're anxious, alert scanning, autonomic hyperactivity. They have sleep problems. They're restless. They can't fall or stay asleep. It leads to social dysfunction. How are we going to diagnose? First, there needs to be an exposure to traumatic event. And you have re-experiencing of the traumatic event via nightmares or flashbacks. High yield the flashback. Okay, in the vignette, if there's a flashback, think, PTSD. Avoidance of trauma-related stimuli. You have negative thoughts or feelings after trauma, and trauma-related arousal and reactivity. The symptoms last for more than 1 month. What's the treatment? CBT. Again, I'm telling you, if you don't know the answer, it's CBT and SSRIs or SNRIs. Another thing, because of that autonomic hyperactivity, we can actually give prazosin, an alpha-1 blocker. Does it affect GQ, GI, or GS? Guys, prazosin, alpha-1, GQ, GI, GS. Kiss-kick. What is prazosin? Kiss-kick, alpha-1, people. GQ, KISS, QISS, right? Alpha-1, alpha-2, beta-1, beta-2. Remember from term 1? KISS, QISS. Don't forget, right? Another example of an alpha-1 blocker used in BPH. BPH, benign prostatic hypertrophy. Amsulosine, excellent. You have your BSc 1 exam, so integrate the materials now, okay? Also, high yield prazosin actually reduces the nightmares, right? Isn't that fascinating? Just by blocking the alpha-1 receptor, well, you are decreasing the autonomic hyperactivity, but it also, high yield, it reduces the nightmares and it improves the sleep. However, what's the downside of all alpha blockers? What's the downside? Orthostatic hypotension. That's why, remember from term 1, if you have orthostatic hypotension, what happens? You have a reflex tachycardia. That's a side effect of your prazosin. Remember those tracings from term 1, your MAP, and all of those blood pressure tracings. Don't forget those. They're high yield. I've seen that on my step. So you avoid benzo or opioids, okay? Why do we need to avoid benzos or opioids? You don't want your patient to be addicted to that. We have an opioid epidemic, people, okay? So please, as much as possible, avoid prescribing benzos or opioids. Why? They have an addiction potential. So that's PTSD. How about acute stress disorder? What's the difference? Timeline. Timeline matters. Less than 1 month. Acute stress, exposure to threat and death, injury, sexual assault. You still have the recurrent intrusive memories. You have recurrent distressing dreams. So what's the treatment? CBT only. CBT, cognitive behavioral therapy, no drugs. Acute stress disorder, less than 1 month. Okay, adjustment disorder. I will tell you. Adjustment disorder is, in your differential diagnosis, it should be the lowest. Okay? It should be the lowest in your differential diagnosis, because if they don't follow the if you check all the symptoms and it's not bipolar, it's not MDD, it's not cyclothymia, it's not those disorders, your fallback always is adjustment disorder. Are we clear? Are we clear? This should be the lowest of all of your differential diagnoses. Okay? This is like a catch-all term. Right? For example, in impeachment, betrayal of public trust. But what is betrayal of public trust? What does it mean? It's a catch-all term. So adjustment disorder, it is a catch-all term. This should be the last in your differential diagnosis. What is it? Behavioral or emotional symptoms. See how vague it is? If you have behavioral or emotional symptoms, like, yeah, it develops within 1 month of stressful life event. You have impairment of daily functioning. Remember, it does not meet criteria for another disorder. As I've said, it's a catch-all term. This should be the last in your differential diagnosis. And it resolves within 6 months. What's the treatment? Different kinds of psychotherapy. Body dysmorphic disorder. Occurs in physically normal patients. Preoccupied with physical appearance. They wanted to become an Instagram famous model, right? They're preoccupied with physical appearance. They focus on minor defects. They believe that they look abnormal, ugly, or deformed. So they keep on checking the mirror. In the vignette, they're going to say they keep on checking the mirror. If they have a problem with the lips, they keep checking on the lips in the mirror. Right? When you're interviewing them, they're combing their hair. If they have a problem with their hair, they keep on checking where split ends. What's the treatment? CBT plus SSRIs. Fluoxetine, paroxetine, citalopram, escitalopram. Now let's go to personality disorders. I don't know if I can finish because I'm on call in the ED at 1 o'clock, but let's see for the time, okay? If I cut it off, I'm gonna do another one tomorrow. Okay, personality disorders. Cluster A, weird. Paranoid, schizoid, schizotypal. Odd and eccentric behavior. Cluster B, personality disorders. Wild. Antisocial, borderline, histrionic, narcissistic, dramatic, erratic behavior. Cluster C is wacky, avoidant, obsessive compulsive, and dependent, anxious, fearful behavior. Let's go one by one. Paranoid. The FBI is after me. They're coming to get me. They are distrustful of others, even friends or family. They are guarded. They are very, very guarded. Sir, can I ask, what's your date of birth? Why do you need to know? They are suspicious, right? Are you trying to steal from me? Why do you need to know? My date of birth. You're going to use that to commit fraud? They struggle to build close relationships. High yield. What's the hallmark? Ego defense. Projection. High yield. Projection. They attribute unacceptable thoughts to others. Schizoid. These people chooses social isolation. They are more comfortable alone. They're loners. They do not enjoy close relationship. They have no interest in sexual experiences. They have no pleasure, no hobbies at all. They lack close friends. They're detached. They have a flat affect. Schizoid, think loners, right? They choose to be alone. That's a difference between schizoid and avoidant personality disorder. In schizoid, they choose to be alone. In avoidant, they want to have a relationship, but they just can't. Okay? Schizotypal. Think odd beliefs or magical thinking. They love horoscopes. They love numerology. They have sixth sense. They are superstitious. They believe in telepathy, right? You have ideas of reference. They believe that the events that's happening somehow is related to them. I didn't get my garbage out this Tuesday, and then we have a spike of COVID-19. Oh, maybe it's because of I didn't put my garbage out during that day. That's a personality disorder. What's the key feature though? They are open to challenges to beliefs. Contrast this one with someone who has delusional disorder. Even though in delusional disorder, even though you challenge them, they are not open, right? You cannot challenge your beliefs. It's a fixed belief. In schizotypal, they are open to challenging the beliefs. They may reconsider the superstition, right? Also, no hallucinations and cognitive impairment. In delusion, commonly seen in schizophrenics, they are not open to challenges to their beliefs. Antisocial personality, more common in men, disregard for rights of others. Before being diagnosed with antisocial personality disorder, Tell me a disorder that must be present in the history.
Conduct disorder before 15.
Excellent. Conduct disorder before 15 years old. Before that, give me another diagnosis that can be seen in the history. So I always think of this as a spectrum, right? It's a spectrum. First, in childhood, you have oppositional defiant disorder, right? Only seen in authority figures, school and home, two settings. And then they progress from oppositional defiant disorder to conduct disorder. In the vignette, they're going to say cruelty to animals, stealing before the age of 15. That's conduct disorder. And then they graduate. So I always think of that as a progression to antisocial personality disorder, wherein you commit crimes now. You break the law, right? You must be at least age 18 years old to be diagnosed with antisocial personality disorder. Next, borderline. Borderline, more common in women. Unstable personal relationships. In the vignette, you can see that. All people are very good or very bad. They have splitting. My girlfriend is the greatest girl in the world, or my girlfriend is the devil incarnate herself. They have a fear of abandonment. They may accuse others of abandoning them. Borderline, think of splitting as a defense mechanism. They're also impulsive. You have spending sprees. They can have sex with strangers or reckless driving. Self-mutilation, don't forget, cutting or burning. And they have suicide gestures or attempts, but you're not going to really plan to complete suicide. So it relates to the fear of the abandonment. For example, you don't care about me, so I'm going to kill myself. What's the behavioral therapy that we're going to use? Dialectical behavioral therapy. It's a form of cognitive behavioral treatment that is designed to treat chronic suicidality. It's a gold standard for borderline personality disorder. Weekly therapy for 1 to 2 years. So they have mindfulness, distress tolerance, and emotion regulation. Histrionic personality disorder, they want to be the center of attention. You probably might know some of these people. They talk loudly. They tell wild stories. They use hand gestures. In the vignette, inappropriate sexually provocative behavior. They're going to tell you, smell good, doctor. You keep on touching you. Right? They often wear provocative clothing. They touch others frequently. They're very concerned with their physical appearance. They have exotic outfits, shoes and hats, probably Louboutin shoes. Narcissistic, histrionic, center of attention. I'm gonna be the center of attention. I'm gonna dress good, right? I'm gonna wear provocative clothing. Contrast that with narcissistic, which has inflated sense of self. They brag. They think that everything they do is great. They lack empathy for others. They think of others as competitors. And they want to hear they are great. Oh, you have such a great presentation. Oh, you're such a great person. I know someone who's narcissistic. They want to hear they are great, right? They overreact to criticism with anger or rage. Okay, guys.
You mean Trump?
Okay, thank you. So that's narcissistic behavior, right? Good. Yep. So avoidant personality. Remember, what's the difference with schizoid and avoidant? Schizoid, they choose self-isolation. In avoidant personality disorder, they avoid social interactions. They have social inhibition, feels inadequate. They're afraid people won't like them. And they are afraid of embarrassment. They struggle with intimate relationship. Maybe he or she doesn't like me. What's the difference from schizoid? They want to socialize, but can't. Schizoid prefers to be alone. So guys,